Okay, well, we'll go ahead and get started. And oh my, I got sirens in the background. For those of you who I have not met yet, I'm Dr. Zeller, and I'm the lead OB instructor for Fortis Online. And I know it's not been a very easy course for what you're trying to get accomplished, but we do try very hard to provide you with the resources you need and the help that you need. And so if you've never reached out to your instructor for a one-on-one session, even if it's only 10 minutes, it might be something that would really help you. Sometimes it's not that you don't know something, it's just there's something else about test taking that you struggle with. So that's why meeting with your instructor, even if it's just one time during the course, is all it takes for the instructor to give you some guidance. So try to do that if you've not done that with your instructor. Well, welcome. We're going to just kind of at the last minute, you might say, for those of you who are testing tomorrow, go over maybe some of the concepts that are more challenging. In OB, you have a lot of new concepts that you will see again in Med-Surg. But so we're having to teach a little Med-Surg in OB as we do diabetes, fluid balance, heart disease, things like that, that you're learning about in Med-Surg. So don't hesitate to ask about any Med-Surg concepts during our session tonight. You know, I have taught not Med-Surg, but I did practice in all areas of nursing. So I do have a good knowledge base and maybe I could help you. So don't hesitate to reach out. Okay. So let's start out with asking, welcoming all of you. Glad you're here. And as people sign on, that's fine. Is there any particular aspects or concepts, understanding key points from weeks 4 through 6 that you really want to talk about again? If you haven't reviewed many instructor videos. So just let me know what you want to talk about, or I'll just start asking you. I'll give you some minutes to do that. Okay. Anything at all? Have you learned in Med-Surg about normal lab values? Have you had to learn some normal labs?
Yes.
Okay.
Yeah.
Because sometimes we just assume in OB that you know normal labs. So if we talk about those, just, you know, a lab value, ask me and I'll tell you what the norms are. Okay. All right. Anybody?
There was some math. There was some math that I'd like to go over that was in the PowerPoint.
Which PowerPoint?
It was the Exam 2 study session PowerPoint. I'm looking for it right now. I'm sorry.
That's okay.
I was wondering about DIC and the lab values for that, like the PT and PTT.
Well, with DIC, the PT and PTT aren't significant to look at. What you would see with DIC are low fibrinogen levels. And you would also see like burst cells. Okay, burst cells. It's not really something you really need to know, I don't think, for the exam, but it's a good question. I think I might have a PowerPoint on that. Or it might be on the original PowerPoint for everybody. Let's see. Did you find the math?
Not yet, but I'm getting closer.
Okay, that's all right. That's all right. Let's see here. Everybody look at the original PowerPoint, the one that we sent out to everybody. It's the one we used to just go over from head to toe. It's a long one. It's got like 60 slides in it.
I have one with 82 pages.
That's probably right.
I think it has like a pink cover page or something.
Yeah, yes.
Exam
That's
two.
got everything in it. Yeah. Even in there, it doesn't talk about lab values of DIC. Okay. All right. Anything else?
Everything.
Everything. So when would you, in pregnancy, in labor and delivery, what situation might you find DIC? What is occurring that triggers DIC in pregnancy?
The placenta abruption.
Yeah, placental abruption. You might see the onset of DIC. So if you suspected it, what kinds of things are you seeing? Clinical
The blood
signs.
leak. The blood leak around the IV sites.
Okay. What else might you see?
Hypertension, like high blood pressure?
I'm sorry?
High blood pressure?
High blood pressure?
It'll be low.
Isn't it low
Vaginal.
blood pressure with tachycardia?
Tachycardia, yeah.
Okay, low blood pressure, probably. She's losing blood.
Yeah, vaginal bleeding.
Yeah.
Blood and urine.
Yeah, she's bleeding everywhere, okay, for disseminated intravascular. Okay, so initially, all the blood vessels throughout the whole body are actually clotting up. Okay, something is triggering it. So it's like clotting, the whole blood is clotting, okay? And because of that, all the factors in the blood that help with clotting are used up. There's no more left. And so then she bleeds out, okay? So it starts with coagulation and it ends up with bleeding out, DIC. So the treatment for that initially, emergently, is to get another IV going and get some fluids running to support her blood pressure, okay? And then oxygen, of course. And then we want to go ahead and give her some clotting factors to help her blood clot, okay? So that would be like fresh frozen plasma. That would have all the necessary clotting factors. Okay, so that's DIC. So what are some of the, when would you see HELP syndrome? What's that associated with?
Preeclampsia.
Or variant of preeclampsia?
Okay, so mild or moderate preeclampsia, we know what that is. If our treatment, our interventions with magnesium are not therapeutic, in other words, the magnesium levels are not high enough to reduce all the symptoms, mother might go into more of a severe preeclampsia. And what we see with severe preeclampsia are two things: higher blood pressure, and usually liver signs. Okay, so HELP syndrome is about the liver. Okay, so hemolysis, which is the breakdown of red blood cells, low platelets. The liver is involved in the function of producing platelets, and then elevated liver enzymes.
You got your back?
Okay, so that's HELP syndrome. Okay, what else?
The math that I was struggling with was a Pitocin rate. So your order is Pitocin at 2 MU per minute.
Okay,
And available is 10 units and 500 milliliters of normal saline. And you need to figure out what to set your pump at. It's slide
So what's-
24 on that set of slides that has 82.
okay. So let me ask you, what is your first step in calculating any oxytocin problem?
Milliliters over hour because you're setting a pump.
Well, we're not going to work on setting the pump yet. The first step is what?
What you
Convert-
have versus the doctor's orders.
The first step is to get rid of the units. Get rid of those units. Use milli-units. Okay? So milli-units. Okay, so if you have 10 units, that's the same thing as how many milli-units? You're just going to add 3 zeros, right?
Okay.
So 10,000 milli-units. Okay, so that's your very first step. Set up your problem as 10,000 milli-units over 500 ml. Okay, that's your very first step. And make sure, even if you're practicing, that you write out the word milli-unit. Okay. Joint Commission is one of the no things. Abbreviations, we always write out milli-units and milligrams, because it's too much cause for error. Okay, so milli-units. And then you have to you set it up however you want to set up then. How much do you have? How much do you need? Okay.
That makes sense. Thank you.
Yeah, so if you have 10,000 milli-units over 500, what is the order? What is the prescription?
Oh, our prescription is 10 units in 500 milliliters of normal saline. That's available. And then the order is Pitocin at 2 milli-units per minute.
Okay, so then you can set up 2 milli-units over and determine how much of your solution contains the 2 milli-units. You know that there's 10,000 milli-units in 500. So then you can just set up your calculation accordingly.
Okay.
Do you use dimensional analysis?
Sometimes, a lot of times I just I just set up 2 equations.
Mhm.
So hold on.
You can share your screen.
So I got 0.1. I don't quite know how to share my screen. I'm sorry.
Okay, that's all right. There should be a green marker, but you probably don't need to do that now.
Okay. Okay.
Let me show you something on my end. Let's see, where do I have that at? Stations. Induction. Oh, I know where I have it. It's in. I'm sorry, I'm just looking for something. It's terrible when you can't find something on your computer. Oh, well, we'll come back to that. Well, anything else?
I seen in week 5 some information about the PKUs for the babies, but I didn't see it like in the review or the slideshow. Do you think there's going to be anything like on that on there?
Okay, well, I can't tell you if there's going to be anything on PKU, but PKU is an inborn error of metabolism. It's something, it's a genetic, it's inherited, okay? It's a genetic disorder. And what it means is that there's a protein found in a lot of foods that's called phenylalanine, okay? People with phenylalanine hydroxylase deficiency cannot metabolize that protein. People with PKU cannot metabolize a certain kind of protein, and that's the phenylalanine. So what happens is if they eat food with that kind of protein, it accumulates in their blood. That protein will accumulate, and it could have an effect on mom cognitive dysfunction. If during a pregnancy, this woman with this inborn error, if she eats food and that level of that phenylalanine is high, it's going to cause damage to a fetus, okay? Cognitive damage, okay? Neurological damage if that protein is too high in her blood, okay? It's called, your book refers to it. In the past, we always called it PKU, but that's phenylalanine in the urine. And really what it is that it's an inability to metabolize that particular protein. They don't have the enzyme to metabolize it. Okay, so if a mother has that and she has higher than what we like levels, we really don't want her to breastfeed, but we always test newborns for PKU. Okay, we might not know for a week out if they have it. If we find out that the newborn does not have it, then baby can breastfeed. Okay, because the baby can metabolize that protein. Okay, so I guess if it's going to be on the exam, they'll probably use the word PKU, and they'll probably say can, and I don't think there's any questions on there about can you breastfeed or anything like that. But just understand that a woman with that disorder, the fetus is susceptible to neuro damage. Okay, does that help? It's kind of a mouthful. Phenylalanine dehydroxylase deficiency. PAD. Okay, that's a good question.
Okay, so I wrote down to focus on preeclampsia, HELP, eclampsia, DIC, lochia, laceration and episiotomy, C-section, like assessment for
Okay,
thromboembolism, postpartum bleeding, and then all the different placenta, like previa and abruption. Anything else that we should like really focus on?
okay, let's do a postpartum assessment together, okay? Do you, okay? Let's do one together. So what is your priority? If you have a client that you've received a report on, what is your focus in the postpartum? What do you know about this particular time of peripartum? And what should your focus be? What are some things you anticipate? I'll give you a client, okay? You have a client who delivered triplets, okay? She delivered them vaginally, okay? What are some concerns you have about this client? What is she at risk for?
Hemorrhage?
Bleeding, hemorrhage,
Bleeding, yeah, hemorrhage. That uterus was stretched, right? Okay. How does the uterus achieve homeostasis? In other words, how does the uterus achieve reducing blood loss? Okay, how does the uterus stop bleeding?
Contracting.
Contractions, regular, good, strong contractions to cause those blood vessels to constrict. Okay, that's how homeostasis is achieved. So homeostasis is a term we use for the ability of the blood to clot and the ability of the blood to dissolve those clots. So back and forth. This is what the body's always doing. Okay. So what is the process of involution? It's the contractions. So where would you expect to see the fundus if your client is 30 minutes after delivery?
Like at the umbilical cord,
The midline.
the belly button.
Your belly button, yeah, the umbilicus, the midline, yes, right there. It could be just a hair above, okay, a little bit above, okay. What else would you want to assess?
If it's like
uterus is
soft
bald and spongy.
or is it hard?
Okay, so we need to assess the consistency of the uterus, the fundus, okay? Is it soft or is it firm? Okay. That's your very first priority when you go in the room. Other than washing your hands, putting your gloves on, introducing yourself, verifying you have the right patient by looking at the armband and asking her what her name is. The first thing you do in your assessment then is to check the fundus. So you're teaching your client, right? So if you go in the room and it's 2 centimeters above and it's displaced to the right, is this normal 3 hours later?
No,
No.
it's not normal.
What do you think else you would find in your assessment?
Bladder,
full
Probably
bladder.
urine. Yeah, full bladder.
A full bladder, and what else?
uterine atony, like it's deviating to the
So there's atony. So the bladder is full. The bladder is preventing that uterus from contracting. So what else would you find in your assessments?
Bleeding.
bleeding, soft,
Yeah, a
spongy,
lot of
body.
vaginal bleeding. Yes. Okay, good. Okay. What would you do? What's your intervention?
Probably tell her to go use the rest, like to urine to pee.
Bedpan,
Yeah, that
And then
you-
massage.
Yeah,
But the
massage,
fundus.
but you've got to get that bladder empty. You got to
Yeah.
empty the bladder first, and then we want to massage. Okay, and we already talked about her lochia. So she voided 500. Wow, she had a full bladder. That's max. Okay, and you help her back to bed. What's the next thing you want to do then?
Put an
The
IV.
massage.
The volume loss.
Okay, so somebody said something about an IV. Yeah, if you suspect she's bleeding a lot and she's going to hemorrhage, make sure she does have an IV access. But we need to massage then. So
Massage the fundus.
Yeah, most OB postpartum have at least an IV site, IV access. But you need to verify that, right? So if she doesn't, and yet you need to massage, you need to call for some help. Okay,
So
so go
what's the
ahead and massage.
priority? What's the priority? Is there massage or is there a IV bolus?
I would massage.
Massage, and then that's the second,
Yeah,
right?
because that
IV
might
is
fix it. That might fix it. Just
Okay.
massaging. And
Would
if you're still,
Sorry, would emptying the bladder be?
That's the
would-
first
wouldn't that be
assessment.
That's the
priority?
first one.
That's the
Yeah,
first one.
first priority and then massage?
Then
Mhm.
Yes.
massage, then IV.
yeah,
and
because
then-
it wouldn't do any good to massage if you still got a full bladder.
Right.
Good questions. So if you had a boggy fundus, she emptied her bladder and it still feels boggy, you're gonna massage,
Better.
okay? If you're having trouble massaging, even though she doesn't have an IV access site, a lot of the medications we give during this period are intramuscular injections. So you could go ahead and give her some oxytocin, hemabate, methyllergonavine, intramuscular while you're getting an IV access. Okay. Yep. All right. So she already has oxytocin infusing in a primary line. What other drugs can we use? I already told you.
Yeah, right.
Misoprostol?
Yeah, and how would you administer misoprostol?
IV?
Intramuscular,
Intramuscular.
subcutaneous,
Is it a suppository?
Suppository.
suppository?
Right? Yes.
It is a rectal suppository. It's a larger dose. Usually we give 200 micrograms. But because it's postpartum bleeding, we're going to give like 1,000 into her rectum. Now, what is a contraindication to using a rectal suppository?
If they had like a third or fourth degree
Laceration.
episiotomy?
Yeah, if they had any sutures, if they had any lacerations anywhere or any sutures, episiotomy, remember, an episiotomy is an intentional cut. Okay, we do that to prevent tearing. Okay, so you have to look and see if she had any sutures. Okay. All right, so some contraindications for methyllergonavine, remember, is blood pressure, any history of any heart disease, high blood pressure, rhythm issue, valve, any kind of heart problem. We're going to avoid anything that causes increase in blood pressure or heart rate. And then hemabate, it's just your asthma.
Asthma.
You're not going to give it. So misoprostol then is what? What kind of a drug is it?
As for cervix ripening and to keep the
Prostaglandin. It's a
Prostaglandin.
prostaglandin. Can you see my slides?
yes.
Yes.
Okay, it's a prostaglandin. Okay, so misoprostol, also known as Cytotec, it's a prostaglandin. What do you know about the drug misoprostol? What else do we use it for?
To keep the pregnancy.
It stimulates contraction.
Yeah.
Well, not to keep the pregnancy. We'll lose a pregnancy if we use it.
What for ectopic pregnancies? No.
For spontaneous abortions to clear out the cervix.
Okay, we could use that or methotrexate.
Mhm.
Okay, what else do we use it for though? Do you remember we're talking about induction of labor? A client that it's indicated that her labor needs to be induced, or she's post-term and we need to go ahead and get labor started. We talked about cervical ripening. So we use misoprostol for that too. Okay, it's a lower dose, of course, because we want that, it causes a cervix to get soft too. So we just put it in the vagina, usually the night before the induction. So inspecting the perineum. So in a situation, what if you go into the room and the uterus is nice and firm, her bladder is empty, you have a good client, she understands how important it is to empty her bladder, but you go to assess the perineum and she has a saturated peripad. Why is she bleeding if her fundus is firm?
Laceration,
Okay,
Hematoma?
Hematoma.
hematoma, yeah.
would you see bleeding from a hematoma?
No, because it's collecting underneath.
Yeah, it's the subcutaneous, it's deeper layers of the tissue. Yeah, so you're just going to notice swelling and it's painful and discoloration probably. It's painful. What would you do if you saw a hematoma?
Call the provider.
Yeah, not much you can do with it. You can apply some ice just to give the client some comfort. So the next thing we would, now that we know bleeding is under control, everything is normal in your assessment, then you can continue on and assess her extremities. And then lastly, or no, there's two more things to do, right? You want to change your gloves, do a breast exam, and assess infant mom bonding. Okay.
Can we talk a little bit about infant mom bonding?
Sure, yes. So what are some behaviors that you would like to see occurring if you are reassured that that the client and the newborn were bonding?
Eye contact.
Okay.
Like laughing, like bonding, like smiling, holding the baby, talking to the baby.
Uh-huh. Now, all the other biorhythmicity and all those other terms we talk about next week. Or I'm sorry, well, we don't really talk about them much, but that has to do with the newborn. Okay, so you don't need to know all those. What else? Bonding. So what would be some of your concerns if your client didn't seem to show any interest in caring for her baby? The baby's always in the bassinet nearby.
Baby blues.
Baby
postpartum
blues or
depression.
postpartum depression.
Would it be depression really yet?
Probably baby blues now, and then later on, postpartum.
Yeah. Unless she has a history of depression, okay? If she has a history, you hopefully you would know that after looking at her chart, that she has a history of depression. So you have to really zero in on what you see and you know, open up the conversation, okay? So what kinds of things, if you suspected your client having some psychosis going on, what kinds of things would you be seeing?
Rapid behavior.
Hallucinations.
Hallucinations, delusions, erratic, did you say erratic behavior? Impulsive,
So, where y'all daddy?
maybe some suicidal ideations?
Yeah, suicidal thoughts.
Mhm. Suicidal, infanticide, homicide. What about depression? What might you see? It was just depression. Maybe she has a history and she's been depressed throughout her pregnancy. The pregnancy went well, but her and her partner don't get along and there's some stress in that relationship. What would be some things you might notice if she was depressed?
She'd be detached from the infant.
Yeah, she might.
Uninterested in doing anything for herself or the baby.
She'll
Right.
be sad.
Huh?
She'll be sad.
Yeah.
Extremely.
Could she be suicidal?
Yes.
Yeah. She could be suicidal, infanticidal, homicidal, even if she's just depressed. You don't have to be psychotic to want to kill somebody or yourself. Okay. So do you feel like you understand the postpartum period as far as priority, what you would see or anticipate based on the client's history? So other than multi-fetal pregnancy, what are some other things that can cause postpartum hemorrhage?
Preeclampsia? No?
No, that's not a direct relationship.
Okay.
What else might
Retained
cause?
placenta?
Okay, if there's
Okay.
some tissue left over in the uterus, you might see postpartum hemorrhage. So it has to be removed. Okay, what else? There's a lot of things.
Precipitous birth.
Okay, so yeah, precipitous labor and birth starts and ends within 3 hours. Good. Okay,
An infection?
an infection, definitely. A bleeding disorder, bleeding disorders.
Uterine atony?
Okay, yeah, uterine atony, definitely. Uh-huh.
What exactly is uterine atony?
I'm sorry, Eddie.
What exactly is uterine atony?
Atony. Okay, atony. What is it to have good muscle tone? If you were to observe a client with really good muscle tone, would you see muscles that were pretty strong enough to just get up, move around, right? Good definition of a muscle, defined muscle. What if you had poor muscle tone? Hypotonia, or even paralysis? You wouldn't see very good definition of a muscle, would you? Poor tone, someone who's like a paraplegic, the muscle tone is just not there. So tonic, when you think about, I'm just trying to use the phrase so that you understand it, but seizures, tonic-clonic activity. Okay, so tone, so if you add an A in front of a word, you're removing it. So atone, atony means no muscle movement or poor muscle movement, almost like hypotonic. So atony and hypotonic are almost the same. Okay, but we always refer to a uterus as boggy as having atony. Okay, so atony. So a diabetic that had a large baby and a lot of amniotic fluid. So polyhydramnios is a situation that sets the client at risk for postpartum hemorrhage. The multi-fetal pregnancies. Anybody remember what immune thrombocytopenia purpura is? ITP. It's a bleeding disorder.
Yeah.
So if there's not adequate platelets, so if you have a client with liver disease and the platelets were low, that would be a reason. If you had a client with von Willebrand, platelets are low. So any kind of disease, those two things that cause low platelets, she's more prone to bleed. Okay. What else? Let's go back to preeclampsia. So can you see the screen? All
Yeah.
right. So 24-year-old, she's 32 weeks gestation. She's gained 25 pounds. Her blood pressure is 148/86. So is this gestational hypertension that has developed, or is it preeclampsia? What cues would What cues would you need to observe to verify that it was preeclampsia?
The blood pressure?
The blood pressure.
Yeah, that's the number one identifier, high blood pressure. So she does have a little high blood pressure, doesn't she?
Yeah.
The 140 is kind of just touching it. Okay. Let's see, where are we? What labs would help you diagnose preeclampsia?
CMP? No.
What would your BMTP be telling you in particular? Basic metabolic profile.
Platelets,
Platelets.
enzymes.
Elevated liver
And
enzymes.
liver enzymes, not the
Enzymes.
platelets. Where do we find the platelets?
PT.
Where do we find the platelets?
CBC?
Yes. So BMP, I don't know what you're calling it, or CMP, right? Or the same thing, basically. It's the chemistry, right?
Mhm.
Chemistry. Okay. Whoops. And then the CBC includes
Proteinuria.
platelets. Okay, then we can do a urinalysis, 24-hour urine, 24 hours, 24-hour urine. For what?
Protein.
And creatinine. Okay. You can also dip
Edema.
your urine, get the that tube you open up, get the strips out and dip it in her urine to assess a lot of things, white blood cells, glucose, protein. So if you dip her urine and you've got 3+ protein in her urine, that means her kidneys are stressed. So she probably has preeclampsia. So those are the most important labs. So liver platelet or liver function test, LFT, or liver enzyme, same thing, liver function test. Okay. So what are some symptoms your client might complain about?
Like floaters, blurry visions, headache that's not
Headache,
going with it.
Floaters in the eyes.
Blurry vision.
Blurry vision.
Slurred
Yeah,
speech.
some cerebral things, right? Something's going on up here in the brain. Her cerebral tissues are irritated. So she got headache, visual changes, things like that going on. What else?
Tachycardia and
Edema?
Edema, pulmonary edema.
Yeah,
Somebody asked me, somebody sent me an email working on NCLEX questions. And the question was generalized edema, and she wanted to choose that, but NCLEX said that was the wrong answer. And it is the wrong answer. Research has shown is that generalized edema is not one of the early signs that you can say they have, because they have preeclampsia, because generalized edema could also be associated with renal failure or renal disease. So that's not just particular to preeclampsia. Maybe hands and feet or facial edema, yes. But most importantly would be pulmonary edema. Okay, so shortness of breath. So headache. What
Well, I have a quick question. I was reading in the book and it said for preeclampsia, and if she was like laboring or whatnot, it said avoid straining, and it said open glottis pushing. What is that?
So what's the epiglottis?
Your mouth area? Your
Oh dear, somebody needs, we need to review some anatomy. So the
Yeah,
epiglottis is what closes the trachea when you
Okay.
swallow food, right? So the glottis is the opening. Okay, the back of the throat, the opening. What we do not want our clients to do is hold their breath and bear down to push. Closed glottis. That was on your first exam. So closed glottis means you're holding your breath and pushing. It's like the Valsalva maneuver. Valsalva maneuver is not a good thing to do for anybody. Why? What's wrong with taking a deep breath and bearing down? Why don't we want our clients to do that?
You tense up, the muscle retracts, I guess.
You don't have oxygen perfusing because you're not breathing during that time.
Or you're holding that pressure in your lungs instead of pushing down.
Okay, so we're holding the pressure in the lungs, bearing down. We're not allowing the heart to beat. It really restrains the heart. So you have reduced blood flow to mom and baby. Okay, so she might get a little lightheaded after doing that. No, we don't. We want her to breathe, learn to breathe open glottis. Okay, exhaling as she's bearing down. It's a little harder to do, but it's possible. Okay. So what prescriptions do we need for a client displaying signs and symptoms of preeclampsia? If the provider decided, let's admit her, what are some prescriptions that you might anticipate?
Magnesium?
Magnesium sulfate.
Magnesium sulfate, yay. Yeah. What else? Is there something else we need? Maybe? Not always.
The antidote for magnesium?
Okay, yeah, it needs to be somewhere nearby. Okay.
What about a diuretic?
No, not a diuretic. If she has preeclampsia, her kidneys are already stressed. We don't want to give her a diuretic. That would make it worse.
Labatol.
What? What'd you say, Samantha?
Labatol. Am I saying it right?
Labetalol, yeah, some kind of antihypertensive. Yeah, labetalol is very common. We use that if her pressure is too high, because we certainly don't want her to stroke, do we? No. Okay. Okay, so that's basically right. So what's the antidote for magnesium toxicity, Ashley?
The calcium gluconate.
Yes, yes, yes. And we push, it's usually 1 gram over 3 minutes. It's rarely used. It's rarely necessary. If you're really monitoring your client every 20 to 30 minutes, it shouldn't get that bad. Okay. So magnesium sulfate is a central nervous system depressant. Understanding that part about magnesium sulfate reminds you of what you need to assess in your client. Okay, so it reduces the activity of the central nervous system. So a little pathophys for you, and you don't have to know this. Researchers have actually scanned the brains of women with preeclampsia, and what they saw is increased activity of the cerebral vessels because calcium levels were too high. Okay, high calcium levels. So in order to treat it, we give magnesium, which balances. So one thing that you might have learned is that in our body, calcium and magnesium are indirectly related. In other words, there's a fine balance between the two. If a client is has hypermagnesiemia, has too much magnesium levels too high, the calcium level tends to be too low, and vice versa. a person with hypercalcemia tends to have too low magnesium. So in the brain, during preeclampsia, there's too much calcium. So we give magnesium, which is a central nervous system depressant. It helps those blood vessels dilate and provide good perfusion to the brain. And that's why we give it to women with preterm labor, because we want the baby to receive that extra magnesium to dilate those babies' vessels to provide good oxygenation to those very, very fragile vessels to prevent cerebral palsy. So magnesium, as you've done in your calculations, we do a bolus. We need to get a larger amount in a short amount of time. 4 to 6 gram bolus in about 30 minutes. And then we do it maintenance. Okay.
So professors, the magnesium goes to the baby and causes like the baby's respiratory to be low?
Yeah, that can happen. Yeah, if the levels are too high, even though it might be good for mother because it's therapeutic, it might reduce the activity of the newborn after delivery. Yeah, good note. That's possible. Yep. But we've got to keep mom therapeutic to prevent seizure activity. Okay. So now that we know that we have to give magnesium, what are your parameters that you're monitoring? In other words, what clinical signs are you monitoring as your client is receiving that magnesium to make sure she is at that therapeutic level between 4 and 7? What do you want to look at?
Vital signs.
Deep tendon reflexes.
Urine output?
And level of consciousness.
Level of consciousness,
Awesome. Yeah. So when you
visual changes.
okay, so we want to know about the central nervous system, which would be visual changes, speech, deep tendon reflexes. Okay. We want to know about respiratory status. She got a good respiratory rate. Is there any problems with shortness of breath? Okay. Any epigastric pain or right upper quadrant
Right upper
pain,
quadrant
which could
pain.
indicate what?
Liver.
The liver. So
Elevated
maybe
liver enzymes.
HELP syndrome if it's worsening. Okay. Urine output. So initially, before treatment, we expect urine output to be less. Okay, because the kidneys are being injured. Okay, so they're not going to be filtering as well. Once we get her therapeutic, it improves urine output. But if she becomes toxic, magnesium can be very toxic to the kidneys. So her urine output drops again. In fact, it might not be any. Okay. So we're looking at creatinine level.
Sorry. So if the urine output is low, that's when you give the calcium gluconate because it's probably toxicity.
I don't think if you know, I don't think you can say that make that blank statement. If her respiratory rate's low, she's bradycardic. If her blood pressure is low, she's got slurred speech. I mean, if she has all the signs of toxicity and we've given her oxygen, we've stimulated her, we've done other things, and we can't improve things, then we will give calcium gluconate. Okay. So that's your preeclampsia. So you have to know those signs and symptoms. So just remember by the systems, brain, lungs, liver and kidneys, and of course, vital signs. Okay, I think that's the end of that PowerPoint though. So that's preeclampsia. So let's say you're treating your client and the baby's delivered and all is well. It's the next day. We usually continue magnesium 24 hours after delivery. How do you evaluate whether that magnesium worked other than all the signs are gone? There's another way we can evaluate it worked.
If the edema is going away.
Okay, so usually if preeclampsia gets to the worst stage, there is some edema, okay, peripheral edema. So we know it worked because remember, once that baby is born and the placenta is delivered, all the blood that's in the uterus, remember the uterus has nearly 3 to 5 liters of blood at the end of pregnancy. That's a lot of blood and it's clamped off. So all that blood in the uterus is then shunted back to the mother's intravascular system. Okay, back to the heart, back to the kidneys, back to everywhere. So now she has to get rid of all that fluid. Okay,
And maybe
so
urine.
so what are the 2 words that we want you need to know that shows the resolve?
Diuresis and peripheral edema.
Okay, so diuresis is urinating a lot. So she might be urinating 3 liters a day. Okay, what else do we want to see besides lots of urination?
Sweating.
Sweating, diaphoresis. Okay, so diaphoresis and diuresis. You know how to spell that?
Diaphoresis and diuresis.
Diaphoresis means sweating or perspiring. And then diuresis means lots of urination. So if you, outside of pregnancy, if you have a client with congestive heart failure, you are giving diuretics and you want to see diuresis, okay? You want to see that occurring.
Would it be absence of clonus too? Like when the clonus?
Okay, what is clonus?
So it's like the shaking after you flex?
Yeah, so the foot dorsiflexing, that's a sign of severe central nervous system irritability. Your client's going to go into seizure activity if you've got clonus going on. Any other questions?
So the patient who has after even delivered the baby, the patient has a still med going on. So the outcome is diaphoresis and diuresis. Got it.
You know, clients can actually develop preeclampsia after the fact. I've had that happen with my clients. They go home after delivery and like 4 days later, they call the office and said they have a headache.
Okay.
That won't go away. So we readmit them and give them magnesium and monitor them for a while.
If preeclampsia originates in because of the placenta, right? So why would it happen after the placenta's out?
Probably leftover placenta.
No, I don't know. It might just be the healing of the decidual, the area where the placenta was attached. It just might be, it still gets aggravated there.
Oh, okay.
So you're not supposed to ask that question, Keisha. Okay. What about, let's go to preterm labor.
Turn that down.
Okay. Preterm labor, what is your management? Let's say it's inevitable. She, her membranes are intact. She's having low back pain, right? Low back pain. And her contractions are regular. She's starting contractions. We admit her to the hospital. We try to, there's no sign of infections. She's 34 weeks pregnant, and we really want to allow this pregnancy to carry on for a while. So we're going to give her some terbutaline, right? If she doesn't have high blood pressure. Okay, so we're trying to suspend contractions. We're trying to stop them. Terbutaline is a tocolytic. Toco means contraction, lytic means to cut or to stop. So tocolytic, stop contractions. Terbutaline. Okay, that's our drug of choice if she's hospitalized. Now we can give other drugs and do other things if she has a history earlier on. Okay, but let's say you have a client that comes in and we can't stop labor. It's inevitable. Okay, it's continuing even with terbutaline. What's your plan? What do we need to do? We've got her hooked up on monitors and she's contracting. What do we need to do?
Do we give betamethasone?
Okay, so if she's 34 weeks pregnant, probably not. But if she's if she's earlier than that, yes, betamethasone. It's a steroid. Why are you giving that, Eddie?
For lung maturity.
That yeah, that's for lung maturity for the fetus.
Okay, so we want to give a steroid to stimulate that surfactant production. What else do we want to do?
Put her on bed rest.
Okay, so she's going to be on bed rest. She's in labor. What was that noise?
That's my child.
So we're given, what else do we need to do? Let me ask you this. What is usually the most common cause of preterm labor?
You said what is used?
I said, what is usually the cause or the common cause of preterm labor?
Diabetes, microstomach baby.
Intrauterine growth restriction.
No, not uterine growth restriction.
Would it be like
The history of preterm labor?
Okay, history. And Catherine mentioned diabetes, extreme prematurity for diabetes. Okay, what else? What's the most common cause?
preeclampsia?
Infection.
Infections.
Infection.
Yes. Ashley did it. Infections. Yes. Genital urinary infection, either from the vagina or from the urinary tract. Okay. So you know that now, right? So as a nurse, you got someone in preterm labor, you're not being able to stop. What else do you want to do?
Antibiotics.
Antibiotics, even though your client is not showing any signs of infection, no fever, no tachycardia, nothing else going on, we're going to give antibiotics. Okay, one more thing.
Don't you, I'm sorry, Professor, don't you have to wait for some lab results to see before giving antibiotics? Or
Good question. Did you see something in clinical? Or did you hear?
No, if I saw, I just, I've been hearing that a lot lately, that before you give antibiotics, you're supposed to wait for the results. But I also heard someone said that what do you do in the meantime? The bacteria is going to keep on growing. But then if you gave antibiotics, how are you going to get a result back?
Right, exactly. So good point. We do a vaginal swab. perineum and in that swab to check for any microorganisms. So usually the cause of most infections could be a group beta strep status. If your client who comes in with preterm labor didn't get any prenatal care, we don't know if she colonizes group beta strep. So that might be a cause of her infection. And so we make an assumption, but we can also culture at the same time. That way, Catherine, we can pinpoint, are we treating
Okay.
it correctly? Are we giving the
Okay.
correct?
And for test purposes, like that would be like real life what we will do. But you know, when we take an exam, sometimes things just don't are like we're
Right.
expecting them to be.
Purposes. And it's a great thing that you brought up. I love it because you're right. We overprescribe antibiotics, and it's always best to do culture if at all possible, if it's safe, okay, and not to just assume. But when you're concerned about, and we know that most preterm labors are caused by infections, we know we can treat with a broad spectrum antibiotic if we have a preterm. The evidence has shown us, okay, so it's okay to go ahead and treat penicillin or vancomycin, whatever, if she's allergic, but penicillin to treat it. But that's a great question. In any scenario when it's not a life or death, if we're, you know, it's like if you show up at the doctor, you think you have a sinus infection and you've been having nasal discharge for 3 days, it's not a good idea just to give you an antibiotic. Okay, we need to culture. And because most times a sinus infection is really not an infection, it's a virus, and it'll clear on its own. Really, the best thing to do is give a steroid. So yeah, we don't want to jump to antibiotics too soon.
So basically, it just depends on what the question is referring to, and then
Yeah, and you're not going to have a question about that on the exam, I can tell you.
okay. Okay, thank you, Professor.
You're welcome. That was a good question. Okay. Let's talk about diabetes a little bit. So if you have a client that has pregestational diabetes, type 1 or type 2, either way, okay, what are some concerns you have early in the pregnancy?
Insulin management or blood sugar management.
Okay.
Like a daily sugar
dietary-
check.
Okay, definitely. What else? During the between 7, 15 to 20 weeks, there's a time during right before that second trimester, just into the second trimester, where the need for insulin is lower. Okay. It's not until after the 20th week we have concerns about the need to increase insulin or medications that a client is taking. Okay. So what if she comes in for her first prenatal visit and she tells you her last A1C a month ago was 8.5? Are you concerned about that?
Then we have to check. We have to check the blood glucose test early.
Okay, so yeah, we certainly want to begin to instruct our clients to test 6 times a day. We want to know what's going on right now. A1C doesn't have a whole lot of value during the pregnancy, but if she told us a month prior it was 8.5, are you concerned that she tends to have hyperglycemia?
Yes.
Yes.
And she's pregnant now. So first part of her pregnancy, what's occurring?
Pre-gestation. Pre-gestational diabetes.
Organogenesis, right? That baby is forming. Ashley, so sweet. Oh, I want that baby. Oh, wow.
She
So
is not cooperating. I'm sorry.
oh, she's fine. She is just fine. So organogenesis is occurring, right? The structures are being formed. If there is hyperglycemia in that first trimester, that baby's systems are being damaged. So congenital anomalies, the heart,
Yeah.
the limbs.
Rose.
Yeah. So that's our main concern during that first trimester. So as she progresses through her pregnancy, what are some things that you're going to see if she does not control her hyperglycemia?
Like a large baby? They
A
grow big?
large baby. Macrosomia, right? Macrosomia. And because the baby's large, because of all of that glucose the baby is getting, baby's urinating more, just like the mother would be if she's hyperglycemic. So there's polyhydramnios.
Polyhydramnios.
Yeah, extra fluid. There's an increased risk of stillbirth. Of course, during that first trimester, it would be an increased risk of miscarriage. Okay. But if she's able to keep the baby, then there's an increased risk of stillbirth. Preeclampsia. She has all the risk, hypertension. Okay. So macrosomia and polyhydramnios. And then as she goes into labor, then we have to consider all the side effects of that, having to deliver a large baby. So injuries to mom and baby, probably a C-section. Infection. So she's a diabetic, so she's prone to infections and DVTs. So when you think of fetal outcomes, because the fetus now has no glucose, once that cord is clamped, we need to get that baby breastfed in the first hour or two, because that baby can easily develop hypoglycemia. And then also the respiratory distress that goes along with high insulin levels. Okay. So know your target glucose levels for your diabetic. I think so it's before breakfast 60 to 95, before lunch 60 to 105, and then 1 hour after a meal less than 140, 2 hours less than 120. I really enjoy taking care of diabetic pregnant women. That and the women with substance use. I don't know why, I just do.
It must be very challenging.
It is very challenging. Okay. That's diabetes. So when would you diagnose gestational diabetes? What is gestational diabetes?
Diabetes that's contracted during the pregnancy.
During pregnancy.
Would you diagnose it after
20 weeks.
20 weeks after the second lab work was done? Because you do a first one and then you repeat it, correct?
Mm-hmm. Okay, so usually gestational is going to develop after that 20th week because insulin resistance keeps going up.
Mm-hmm.
Okay, so we do the glucose tolerance test, usually at week 28. Okay. If we suspect that based on client history, she's Hispanic, she's obese, she had it before, family history, then we might do it before 28 weeks. Okay, so we do the glucose tolerance test. It lets us know if she can metabolize that glucose we give her. Okay. All right. Okay. All right. What's gestational hypertension?
Hypertension acquired during the pregnancy.
Yeah, after 20 weeks, and everything's after 20 weeks, right?
Mhm.
That's the golden week. Okay. All right. I think we've covered just about everything. What about bleeding? If you have a client that is 12 weeks pregnant and she calls the office and says she's bleeding, what else do you want to know?
How much of the bleeding is?
Okay.
What
What
what the coloration of the blood?
Any abdominal pain?
Okay, we need to ask her if she's hurting. Okay. Because if she's got cramps going on, what does that indicate?
Miscarriage.
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 Inevitable. It's an inevitable. So cervix is open and she's cramping and she's bleeding. Okay. So what would you do? Would you just say, "Oh, I'm sorry"?
Tell her to come in the office or go to
What
the
would you-
hospital.
Well, she could come to the office. What would you do if she came into the office?
Ultrasound.
Okay. Okay. We might also draw an HC.
An HCG.
Yeah, HCG, because her first one, compare it to the very first one she had drawn. And if she's having a miscarriage, it's going to drop. Okay. Okay. What if she is 24 weeks and she's bleeding?
Do we give like medical management maybe to try to save it? Like side attack?
Oh, side attack, you're going to get rid of the pregnancy. It's going to cause contractions.
You gotta do something to try to keep the fetus in as long as possible.
So are you talking about a threatened abortion?
Yeah, threatened abortion.
So a threatened abortion, she's going to be bleeding, but she's not going to be hurting. Okay, that's the difference between, and the cervix is going to be closed.
Could it be that she's experiencing like I mean, I don't know how to, I'm sorry for my baby in the back. Hold on, I'm sorry. Could it be like when they get like their period, not get their period, but some left from the implantation? I don't know.
Okay, so if she has early bleeding, like a couple weeks out, it's more of an implantation bleeding, but that's like, day 15 or something. It's not, it's just a couple weeks into her pregnancy.
You said 24 weeks. That's right. I'm sorry.
Yeah, and yeah, that's okay. That's okay. So at 24 weeks, why could she be bleeding?
Could it be that she's having some lower, something is pushing, like the baby is pushing, not, do you get what I'm saying? Like it's, I'm sorry.
Placenta previa?
Placenta previa, yeah. But
There we
that
go.
is usually that's diagnosed on the ultrasound. So every client at 20 weeks gets a general, it's called a gross anatomy, just looking at the baby, looking for all the parts. And usually if there's a previa, we see it, okay? If we do one before that, we might see it, but sometimes because the uterus grows as a pregnancy, sometimes low-lying placentas actually end up higher up. So we might see a low-lying placenta, but it's resolved as a pregnancy progresses. But at week 20, if it's low-lying, we're a little concerned. If it's completely covering the cervix, what does that mean?
Does she has to have a C-section?
Yeah, so we need to educate her, right? She needs to take it easy, no strenuous exercise. She probably needs to avoid intercourse, nothing in the vagina, and to let us know if she starts cramping, and just monitor her very carefully. We probably would do non-stress tests too. Okay. So what's the difference between a previa and a placenta? That pulls away very rapidly? What signs would you see?
Or like a lot of pain if it was the placenta abruption with darker red bleeding. Like
A lot of bleeding, yeah, a lot of pain.
Would
And
it-
the uterus would be tender and it would be firm. What'd you say, Andy?
I was gonna say if there would be a rigid abdomen.
Yeah, a rigid abdomen. Mhm. With previa, there's no pain, just some bleeding, bright red bleeding that comes and goes. Just depends where the previa is. Okay. Well, I don't have anything else. Does anybody have anything else they want to ask about?
It's definitely helped out a lot.
Good, good. I'm glad. I'll
you.
post the recording to your class, or I'll have your, see, Eddie, remind me, who's your instructor?
Professor McGuffey.
Tessa, that's right. Okay.
How about the PowerPoint that you had?
I'm sorry?
How about the PowerPoint that you had? Do we have that accessible to us?
Yeah, which one in particular? The one,
Now you were going over the diabetes one. I saw that one was
yeah,
completely
you should
different.
have that one. That was
Oh, yeah.
mine. That's a PowerPoint I used, but I'll send it to you. I'll send it again, just in case.
Thank you.
Okay, so you can go sign off unless you have a question. I'll just sit here and wait until everybody's questions are answered.
Thank you.
You're welcome, Tanisha. Glad
Professor.
you were here.
Thank you very much.
You're welcome, Lisa.
Thank you, Professor.
Ashley, I want to see that baby's face.
Hold on, hold on.
Oh, let me see that face.
She is something. Say hi, Harley.
Oh, honey.
Say hi.
Sweetie. Oh, what a sweetie.
Oh my
She's a big
goodness.
girl. All right,
Thank
Ashley.
you.
Take
Thank
care
you.
of her. You're
Thank you,
welcome.
Professor.
Professor,
Thank
greatly
you, Catherine.
appreciate it.
You're welcome, Eddie. I'm glad you were here.
Thank you, Professor.
You're welcome. How do you
Bye.
pronounce your name? Sway? Sally?
Swiley.
Swiley?
Swiley.
Swai. Okay. Nice.
Thank you. All right. I look forward to your PowerPoint.
Okay, I'll get it to you.
All right. Thanks. Bye.
Bye-bye.